So we move on to our next segment. So everyone's ready for the same? So the next segment is the one which is the most important. As I said, I hardly get any of it. But to get your nerves right is the Neuroophthalmology segment. And I request the chairs for the session, Dr. Rohit Saxena sir and Dr. Digvijay Singh sir, to come to the dais, please. So Digvijay Singh sir is the director of Noble Eye Care and also the head of the department at Narayana Gurgaon. And his expertise is pediatric ophthalmology and glaucoma. So, Dr. Rohit Saxena sir is yet to join us, and I will take over from there. So I request Dr. Digvijay Singh sir to please take the first class of this session, and that is Neuroophthalmology Basics, Anatomy, and Investigations.
Thank you. Thank you so much, and it's great to have a packed house in the morning. Neuro-ophthalmology is something that we'll all come across in our practices, in your examinations, in your PG rounds, and it's something that sometimes perplexes us. It used to initially for me as well, but as we realize, it's a very logical sort of a branch, and it's a branch where if you know your neuroanatomy well, if you know your examination well, one, you get to see lots of classical signs there, but if you know them well, then you're actually able to, diagnose the patients very well, present a good case to the examiner, as well as, do a good algorithmic approach to the investigation and management. So today I'm going to cover neuro-ophthalmology, the anatomy, which is basically going to be the clinical anatomy, essentially referring to anatomy that is, most relevant to us. And this is going to be followed by a brief about the history taking the examination, and so that essentially sums up the whole of the talk that I'll be giving you now. Is this pointing? Okay. Yeah. So in the anatomy, I think basically if you look at what you need to know about the neuroophthalmic anatomy, these are the top 7 or 8 points that you need to know. You need to know a little bit about the bony anatomy, and that actually overlaps with what our oculoplasty colleagues would be telling us. You need to know anatomy about the afferent system, the efferent system, which includes all the cranial nerves, specifically the pupillary pathways and we'll come to each one of these as we go along. You need to know anatomy right up to the vascular anatomy. Of course, the facial nerve, the trigeminal nerves are all actually part of the neuroophthalmic anatomy, and we need to know all about them as well. So we will come to these now one by one. So first and foremost, the bony anatomy of the orbit. You should all be familiar with the bones that form the orbit, the parts of the bones that form the fissure, the superior orbital fissure, the spaces between them, the inferior orbital fissure. You need to know the optic canal. So these are things that you should know offhand, and what forms the boundaries of the orbit and these fissures as well. And this is important because we know that there are specific nerves and vessels that come out of specific fissures within the orbit. So for example, you've got the superior orbital fissure, which is the largest fissure in the orbit here, if I'll use this pointer. And you can see that it's got the lacrimal, the frontal, and the trochlear nerve coming out of it. It's got the superior ophthalmic vein. Then you have this large black circle that you're seeing here, which is actually the tendinous ring of Zinn. And this is where all the tendons of the extraocular muscles come and attach. And within this, you have some part of the superior orbital fissure as well, which has the abducens nerve, as well as it's got branches of the trigeminal nerve. And it also has the optic canal within this tendinous ring of Zinn, which has got the optic nerve as well as the ophthalmic artery. And as we go down, we reach the end of the superior orbital fissure, and then below that is the inferior orbital fissure, which again has nerves of the fifth cranial nerve, as well as infraorbital nerve and arteries there as well. So you should be very familiar with this anatomy, again from a clinical standpoint, because when we will be coming to clinical syndromes such as the superior orbital fissure syndrome or the orbital apex syndrome, if you know this anatomy well, you'll be able to make a good diagnosis. Then the base of the skull anatomy or the cranial fossa anatomy is again something that you should be familiar with if you're going to be looking at a neuroophthalmic practice. A very important part of the anatomy is the cavernous sinus anatomy, and this is because a lot of the cranial nerves that are actually coming to the eye are actually passing through the cavernous sinus. Again, the sella turcica below, as you can see, the saddle shape right at the bottom, on top of which is the pituitary or the hypophysis, the stalk, and then on the sides you have these cavernous sinuses, which are having the carotid artery, internal carotid artery going between them, and they also have the oculomotor nerve right on top, then the trochlear nerve, and then they've got branches of the trigeminal nerve along the lateral margin, and medial to that is the abducens nerve. So again, this is an important question that also can be an MCQ question as to which nerve is located. And you also need to know this because from a clinical standpoint, if there is anything that's happening to the internal carotid artery here in the form of, let's say, an aneurysm, or there's any other infection or a cavernous sinus thrombosis, then these are the nerves that are going to get affected. So you should be well aware of this as well. Now let's come to the optic nerve. We're now looking at the efferent pathways. So the optic nerve is originating from the globe, and it is going all the way back up to the chiasma. So there are different parts of the optic nerve. There is one which is the part within the orbit, which again is about 1 millimeter within the globe area, and then you've got the next 25 or 26 millimeters, which is within the orbit or the intraorbital part. This is usually tortuous to allow for the eyes to move around. Then you have the intracanaliculaar part, which is within the optic canal, as we had seen in the bony orbit before. And then beyond that, you've got the intracranial part. So roughly the intracranial and intracanalicular part together equals to the intraorbital part, if you want to know about that in terms of the rough estimates, 1 millimeter here or there. Then the optic nerve is about 1.5 millimeter where it originates at the optic disc. We all know that. And that becomes much thicker at the back once it has crossed the lamina cribrosa. Once you have the dural sheaths which have come along with it, and the myelin has joined in as well. So again, these are all questions that can often be asked in your Viva, in your MCQs, so you should be aware of that. So, and what forms the optic nerve? Essentially, these are the axons of the retinal ganglion cell. So you've got the rods and cones which are going on to the bipolar cells, which are then going on to the retinal ganglion cells, and those axons are what is forming the optic nerve. The optic nerve is not a true nerve in the sense that it's actually a part of the central nervous system. Embryologically, it is coming from the diencephalon. So it's different from the other nerves in that sense. So in one way, the word nerve there is actually a misnomer for the optic nerve. Now, you need to know about the pathway beyond now the optic nerve itself. So the optic nerve goes on to the chiasma where the fibers decussate. They don't decussate fully. There's a 53% to a 47% ratio of the decussation there. And you will be learning about these further, I think, in the neurovisual fields that you'll be coming to. So I've made that diagram a little small on this side. That probably will get covered in localizing the lesion in the future talk, in the next talks after this. So these decussate at the chiasma, and then after that, the crossed fibers form the optic tract. They go on to the lateral geniculate body, which is actually 6-layered nucleus. So 1, 4, and 6 nucleus is getting it from the contralateral or the crossed fibers actually, and 2, 3, and 5 layers are getting it from the ipsilateral fibers. From there are branches which are going to the pretectal area. There are branches which are, and then it forms the optic radiation, which is going to go, or also can be called the geniculocalcarine tract, because it's going to go to the calcarine sulcus in the brain, which is where in the occipital lobe, which is where our visual cortex is, which is Brodmann area 17 or the fourth area of the visual cortex. And so you should be very familiar with all of this anatomy, and I think this is something that probably we already are familiar with, I'm sure. But if you're not, you get familiar with that, because this essentially forms the crux of the entire visual fields exercise that you will be doing after this to look at where the lesion is going to be. But you have these wonderful diagrams that you can actually look up on the internet and in textbooks, where you can look at this, they're so color-coded, and they can actually guide you with regard to the various field defects based on where the lesion is going to lie. Now, the efferent pathway is also very important, which is predominantly the pupillary pathway or the parasympathetic pathway. Now, as we had seen that there were some fibers from the afferent visual pathway that were going on to the pretectum. So from there, they give an input to the Edinger-Westphal nucleus, which is from where the pupillary fibers are originating. They also get some input from the cortex directly. And these fibers then go on to the ciliary ganglion along with the oculomotor nerve, and from where they go via the ciliary nerves onto the pupillary muscles. So this is again the pathway that's very important, because in pupillary reactions you need to know about this pathway. Only then you can actually decipher what is going wrong and where it is going wrong. And the pupillomotor fibers are actually on the outsides of the oculomotor nerve, so therefore any compressive lesions tend to affect the pupil size in a third nerve palsy. Then let's look at the oculomotor nerves, and we'll come to the I'm going through these very quickly because there's a lot of anatomy, but the idea is you should be familiar with all these diagrams and you should know about the pathways. Oculomotor nerve is coming from the midbrain. It comes at the level of the superior colliculus. It is going through the red nucleus, through the substantia nigra. It is exiting at the ventral side of the midbrain, between the posterior cerebral artery and the superior cerebellar artery, from where it goes and enters into the cavernous sinus. It gets the pupillary fibers on the way. So just imagine the whole pathway going through the cavernous sinus, where it's going to split into a superior and an inferior division, which is going to supply different. So the superior division will supply the levator palpebral superiorus as well as the superior rectors. The inferior division goes on to the medial rectors, the inferior rectors, the inferior oblique, which get further subdivided as it enters the orbit through the superior orbital fissure. So if you, again, you should be familiar with this anatomy, because based on where in the path it is getting affected, you may see different changes or different clinical signs and symptoms. The trochlear nerve is a unique nerve. One, it is the smallest nerve that is there, thinnest nerve, about 2400 axons. It exits dorsally. So this is at the level of the inferior colliculus in the midbrain. It is exiting dorsally. All other nerves are exiting ventrally. It crosses over. All the other nerves are not crossing over. So here you have a contralateral, if the nucleus is involved, there's a contralateral nerve palsy that comes about. It is crossing over. It's a very thin nerve, very often gets damaged in head traumas, even trivial head traumas. Trivial head traumas can damage it. It's going again through the cavernous sinus just below the oculomotor nerve, it has passed between the posterior cerebral artery, the superior cerebellar artery, and again it enters the orbit and supplies it breaks up into smaller nerve, I would say branches, and supplies the superior oblique muscle alone in the proximal 1/3. Again, be familiar with this nerve and the unique characteristics of this particular nerve. The trigeminal nerve is again a nerve anatomy that you should know of, though it is slightly less important than the other cranial nerves that we see on a day-to-day basis. But again, you should know there's a motor nucleus, there is a sensory nucleus. This all goes into the trigeminal ganglion, and then from there on, it supplies different parts. So get familiar with this anatomy as well. I'm not going to spend much time on this. The abducens nerve anatomy, again an important nerve. We'll all be also talking about paralytic strabismus later in this session. So this nerve is coming further down now from the pons level. So it has shifted. So we can see from midbrain, we have come further down towards the pons. It is going through the facial colliculus, which is a curve of the facial nerve. It is exiting ventrally, goes into the Derolis canal at the petrous apex of the temporal bone, and that's why, because of high pressures in the brain, sometimes it gets depressed there, and you can have false localizing sign of abducens palsy. Again, it enters the cavernous sinus medial, as we had learned earlier, to the oculomotor and the trochlear nerve, enters the orbit and supplies the lateral rectus. The facial nerve anatomy is again an anatomy that you should be familiar with. I won't spend much time, but remember that this has it's a motor nerve and has different branches. It also supplies the lacrimal gland in the eye, and you should again be basically familiar with the anatomy of this nerve as well. The oculosympathetic pathway, again a lot of questions come from this, which is related to Horner syndrome. This is a pathway which is, earlier it was the parasympathetic pathway, partly of the pupillary, that was going along the pupillary fibers. Now this is the oculosympathetic pathway, originating from the hypothalamus, the first order neurons going right down to the spine. So remember, there are no sympathetic ganglion above the cervical spine area. So if anything sympathetic supply to the face has to first go down in the first order neuron. It synapses there at the C8 T1 area on the sympathetic ganglion there, from where the second order neurons will start climbing up, rising up. So it has already gone far down, almost to the lung, apex of the lung area. Then it has started to rise up as a second order neuron, which is now going to the cervical ganglion or the superior sympathetic ganglion, and then from the superior cervical ganglion it is going to go further to the ciliary ganglion in the orbit. So that's the third order neuron, goes from beyond the ciliary ganglion in the orbit. Again, and these are going to give supplies on the way to the sweat glands as well as to the Muller muscle and the pupil. So based on where it's getting affected, whether it's preganglionic or postganglionic, you can decide on terms of the clinical symptoms as well as how the pupils react. You should be familiar with Horner syndrome and how to differentiate pre and post-ganglionic. The last thing in anatomy that I'm going to cover is the vascular anatomy. You should be all very familiar with the blood supply to the optic nerve, to the retina, to how the ophthalmic artery comes in, the pile vessels, the short posterior ciliary arteries. You should be familiar with the blood supply of the brain, the circle of Willis. And because all this is important because there's a lot of vascular aspect that happens in neuroophthalmology. A lot of ischemic neuroophthalmology ischemic changes happen or ischemic damages happen to the nerve. So you should be familiar with this. And then I've also put the venous anatomy here, which you can see in blue. This venous anatomy is essentially of the venous sinuses. Again, important from a standpoint of raised intracranial tension when there is a venous sinus thrombosis, but you have the superior sagittal sinus going on to the to the sigmoid, the transverse sinus, and the sigmoid sinus. So be familiar with this anatomy. I won't spend too much more time for want of the time. Now let's quickly move on to the clinical aspect of the neuro-ophthalmology evaluation. Again, as in any clinical situation, you got the history, then you got the examination, and you got some the ocular examination, the systemic examination, certain investigations that have to be done. In terms of history, probably the most important history and the most common history that we'll get is vision loss for a lot of cases involving neuro-ophthalmology. So the onset of vision loss tells us a lot. Was it subacute, acute, or hyperacute, which happened within minutes? That is most likely a vascular cause, some kind of a stroke. Or was it something that happened over a period of hours or days, going into the category of subacute or acute, which again could be ischemic, it could be also inflammatory, traumatic would be hyperacute, and then something that is happening chronically over time. So these are based on how the vision has been lost. You can actually find your possible differential diagnosis. So very chronic ones would be, let's say, things like tumors or things like toxic neuropathies. They will happen over a long period of time. In history taking, it's very important to take a history beyond just that of the vision loss or double vision, but also a systemic history, a history with regard to the family, treatment history, because this all matters. In treatment history, very important to take history of, let's say, drugs being taken for tuberculosis, for example, which can affect the optic nerve. Family history is important from hereditary optic neuropathy standpoint. Systemic history, any focal neurological deficits that the person has had in the past, any tremors, anything else that kind of helps you connect two systems together. Now, in examination, visual acuity, I think we all do this all the time from the Snellen. It actually is fairly adequate to do it from the Snellen vision chart. A lot of these patients with neuro-ophthalmic problems may actually have very poor visual acuity, but it's very important still to document that accurately. Is it finger counting close to face? Is it at 1 meter, half meter, 2 meters? Because their improvement can actually be judged from that basis. A finger counting at 1 meter is very different from a finger counting at 3 meters, for example. And there is a change or an improvement that you may have missed if you don't do it properly. Even from basis of history, you can take an visual acuity before that. Could the person see the television before? Could he, look at objects? Could he see his food in his, in the utensil as he was eating? So these are small things that you can do historically to take to assess the visual acuity. Another thing that will give you good plus points is if you're able to do a good confrontation visual fields, or basically bedside as you're examining your patient in, let's say, the rounds, and even in the clinic. It's something that I use very often and very quickly. One, to judge if there's any gross defect, because these neuro-ophthalmic defects are very often absolute defects. So confrontation field would tell you very clearly what it is. It also helps the patient realize that there is a problem. And the best way of doing it is to compare it with your own visual field, essentially, which is to get the patient right opposite you, and you're closing your corresponding eyes. If I'm closing my right eye, the patient is closing his left eye. So his right eye and my right eye are looking at each other. And then you can use an object from the side to see where you can judge it first time versus him. So essentially you're comparing this with yourself. So you should be familiar with how to do a confrontation visual field, practice it with your friends and colleagues. Let's move on to the pupillary reaction. So in the pupil, you want to look at the pupil reaction. First, you want to look at the pupil size, shape, reaction to light, reaction to near, in dark, in light, in bright light conditions. Also, near vision is very important in the visual acuity, which again, sometimes will be associated with the pupillary defect there. We've already discussed the pupillary reactions, that it's coming from the Edinger-Westphal through the interneurons, and it's going, from the pretectum, which is where the interneurons are, to the Edinger-Westphal. That's where the afferent is connecting with the efferent, and then from there on it goes via the oculomotor nerve to the ciliary ganglion. So pupillary size is very, very important. So normally it should be round. Of course, the size keeps varying based on light, but you must measure and you must see if the two pupils are similar or are they different from each other. Is there an anisocoria as well? The shape is important as well. Then you need to look at the pupillary reactions, and we'll come to that. We know that presence of an RAPD is a very, very significant find in ophthalmology. So don't dilate your patients till you've actually looked at an RAPD. Don't do that. Don't make that mistake. You must look for the Marcus gun pupil as well as the pupillary reactions. The reactions can be done with a swinging flashlight test, which is a simple test where you're asking the patient to look at a far distance in a darkened room, and you're swinging a torchlight from one pupil to the other in the visual axis. Remember, if there is a strabismus, and this is a question that is asked, then the light should be in the visual axis. So you have to move your torch accordingly. If, let's say, it's a large angle exotropia, or a large angle esotropia. And based on how the reactions are, you can tell whether there's an RAPD or not. And you also have to look at the direct reaction, the consensual reaction. So these are again something that you must be very familiar with. And again, practice this in all your patients. You must do pupillary reactions, even in patients who are absolutely normal. Make it a routine habit to do the pupillary reactions and look at it. Let's move on to the fundus examination, which is probably one of the most important parts of this examination. You want to do a dilated fundus examination ideally on all cases after you've looked at your pupillary reactions. You can use a direct ophthalmoscope. You can use the slit lamp biomicroscope, which works very well. You should do an indirect ophthalmoscopy to look at the periphery of the retina, because a lot of cases of neuroophthalmology also involve other retinal conditions. For the optic disc, you want to look at the size of the disc. So it can be measured by either using the small cone on the direct ophthalmoscope, or you can you can use the lens and accordingly put a correction. So with, let's say, 90D lens, a 1.3 millimeter multiplication of the size that you get on the slit lamp scale can be done. This helps you differentiate optic nerve hypoplasia specifically. Where the size of the disc itself is small, it may be pale. Both discs a normal size disc could be pale, a hypoplastic disc is pale, but the size can help you differentiate between the two. You want to look at the disc's shape. Discs usually are circular or slightly oval, but there could be different shapes. There could be tilted, there could be notches in the disc, there could be hypoplasia of some part of the disc. So the shape is important. The color is important. Normally it is kind of salmon pink, but if it is white or yellow, pale, or more pinkish, that's more hyperemic. All of that is significant for us. Very, very important. The neuroretinal rim is important. How is the rim placed? The cup disc ratio is more important from a glaucoma perspective, but you can also have pseudo-cupping in neuroophthalmology. So you can have a larger cup disc ratio even in cases where there's an axonal dropout because of, let's say, a toxic neuropathy or a compressive neuropathy. Disc vascularity is important. You should know about the Kestenbaum sign. So I think essentially you should be a master of the optic disc examination. That is very, very important. Looking at the peripapillary area is very, very important as well. So this is what a normal disc would look like. And you can look like a disc with papillitis below here. Just use this pointer that you can see it's hyperemic. The margins are blurred. Then this is a primary optic atrophy in a toxic neuropathy. You can see temporal pallor. The disc margins are well defined in both of these. Below you can see that the disc margins are now again lost. You can see they're feathery. You cannot see the cup. You can see a peripapillary hemorrhage in the picture below. So these are all things you should be able to describe actually. The diagnosis comes later, but to be able to describe your findings, that is very, very important. Here you can see a pallid disc above. This is an anterior ischemic optic neuropathy. Below you can see myelinated disc fibers. So don't get this confused with any of the other disc pathologies. This at best could lead to probably a slightly enlarged blind spot, but this is not going to lead to any vision loss. Neuroretinitis, so that's where the retina examination becomes important. You can see this star, macular star that develops here. And of course, papilledema, that is a severe disc edema in both the eyes that you'll get to see. The disc margin, cup is obscured, the vessels may be tortuous, the margins are obviously totally blurred, the disc is substantially elevated if you're doing a stereoscopic examination. So all this is important. Differentiating primary optic atrophy from a secondary optic atrophy is important. You must know the points of differentiation between them. Of course, you can see the margins are very well clear in the primary optic atrophy. They are not distinct in the secondary optic atrophy. Secondary optic atrophies will give you a dirty gray-white kind of a color. Primary optic atrophy, a pale yellow color. So some of these things you must be aware of. After the ophthalmic examination, and I've left out some of the extraocular muscle examinations here because that I think will be covered in the paralytic strabismus talk that you'll have next. So next comes the systemic examination, and here this is important because in a case of neuroophthalmology, you must look at the system as a whole. Obviously, we have to do the standard, which is everything from the cardiovascular to the CNS to the GI, and that should be a part and parcel of your examination routine as well during your examinations. But specifically from the cranial nerve point of view, we must look at the person's gait as the person is walking in. And if you make comments on this, this is actually it's like a plus point in your examination. You must do the full cranial nerve examinations from the top down, the appearance of the patient. You must look at the cerebellar signs. You must look at motor, sensory. So again, but if you do this, if you practice this, then you will get very quick at it. It sometimes takes us only about 2-3 minutes to actually do a quick CNS examination in any patient. In investigations, from a neuroophthalmology standpoint, there's some investigation that you can do easily on the bedside or in your clinic itself. That's the color vision and the contrast sensitivity. There are some which will require a further, evaluation, such as the visual fields or the optical coherence tomography or the visual evoked response. So color vision, you can use a standard Ishihara chart as well. but there are different forms of color vision. Again, something that you must be familiar with is color vision testing, as well as color vision deficiencies for ophthalmology, and this is the right time to read about it and know about it, because later on you'll just be using them in practice. So make sure you know very well about color vision at this stage. It's something that we often ignore, or we often put it behind in our priorities. We know that, of course, red-green gets affected more in the optic nerve conditions as compared to blue-yellow. Contrast sensitivity, again, it's a sign which is an early sign in neuroophthalmic conditions, and you can look at this Pelly-Robson contrast chart that we see here, and this is lost in neuroophthalmic or optic nerve conditions and often may not even recover. So we should be familiar with this. Visual fields, of course, will be discussed in details later. It's something that you must be familiar with. More than the static field, I think you should all at least be familiar with this chart, which is the kinetic perimetry, or the golden kinetic perimetry, with these isopters here, the blind spot. You can see central scotomas up there, and the matching static field is below. So you should be familiar with this, even if it's not there in your institutions. I think, look at some YouTube videos, go through this and get aware of what the Goldman kinetic perimeter is. A lot of them have now come in the automated form as well. Visually evoked responses, again, a very something that tells us functionally about how the optic nerve and the whole visual pathway actually is doing. And you should be aware of how to read a VER report or a VEP report, different forms of VEP, flash, pattern, and how it is done. So go to the VEP lab and go and have a look at it once for yourself. And if they have time, get it done on yourself once and you will realize. The optical coherence tomography, of course, we're all very familiar with. This is an older picture there, but you should be aware of the optic nerve cube, how to read the optic disc OCT, as well as looking at the RNFL and what changes do we look at, how does disc edema look at on the OCT. Though the OCT is not something, it shouldn't be the first thing that you blurt out if somebody asks you, how will you manage your patient? There are a lot of, you should always talk about it in a systemic format, as I've been discussing here with you. So then there are other systemic investigations that you want to do in terms of the blood. You should know what all neuroophthalmic conditions we often do. We want to look at specifically where do we want to look at the ESR CRP, for example, if you're looking at an anterior ischemic optic neuropathy, or when you want to do the autoimmune profile. So you should be familiar with these, and this I think will happen as you will see cases through your through your residency and your training. So this kind of sums up neuroophthalmic examination, clinical anatomy and examination for you guys. And if there are any questions, we'll be happy to take them up. And you'll also learn some of these things I've left out here in this talk deliberately to shorten time, because they will be covered now in the next 2-3 talks that we'll be hearing just after this. Thank you.
Thank you, Dr. Digvijay. An excellent overview of the examination techniques, anatomy for neuroophthalmology that as a postgraduate you should know. Any questions while I invite the next speaker, Dr. Swati Fuljale, who's going to be talking to us about paralytic strabismus. She is an additional professor at RP Center, AIMS, New Delhi, with a vast experience in neuroophthalmology and strabismus, and she'll be talking about paralytic strabismus. But any questions or any doubts in the meantime? When in doubt, just shout. You can interrupt any of the speakers, वैसे तो, but okay, then good. It appears that neuroophthalmology is crystal clear to you all. So, Dr. Swati, talking on paralytic strabismus.
Yeah, I would like to begin with thank you to Team CFS for inviting me here and allowing me to give this talk. I would also like to thank Dr. Digvijay for making all the life easy for all subsequent speakers. He has comprehensively covered how to examine the various aspects of neuroophthalmology, and also has covered anatomy in very detail, so that makes my life easy. I don't have to go through that part. To begin with, strabismus can be classified as comitant, incomitant. I'm sure we all know this. Incomitant can again be classified. So incomitance has its own characteristic features, like incomitance of deviation. So the deviations are different in different gazes. There is limitation of ocular movement, and there is difference in primary and secondary deviation. So secondary deviation is always more than primary deviation in cases of incomitant strabismus. It can further be classified as restrictive and paralytic. So just by clinical examination, you can tell whether it's a restrictive strabismus or paralytic strabismus when you match the amount of deviation with the amount of limitation. So generally in paralytic strabismus, the amount of deviation is much more as compared to restrictive strabismus, where the amount of deviation is less as compared to the amount of limitation of ocular movement. So that's the basic clinical classification, and that's how you will examine, you will proceed to a case of paralytic strabismus. So paralytic strabismus there can be neurological causes in form of third nerve palsies, fourth nerve palsies, and sixth nerve palsies, which will form the major bulk of this presentation. There can be neuromuscular junction problem as in myasthenia gravis, or the muscle itself may be at fault as in chronic external ophthalmoplegia. So to begin with, the clinical features, of course, include head posture so that the patient maintains binocularity. You have to take measurements in all 9 gazes, to do diplopia charting, Hess charting, do a force duction test and active force generation test as a basic clinical examination. So coming to third nerve palsy can be classified as congenital or acquired, pupil involving or pupil sparing, complete or partial or isolated depending on the location of lesion. So generally the patient presents with divergent strabismus. Pupil may or may not be involved, again depending on the etiology and location, but yes, most of the cases pupil may be involved. There is ptosis because third nerve supplies almost LPS also, and it can be a part of various syndromes also. So the patient will come with the complaints of both horizontal as well as vertical strabismus. The common etiology include, it can be congenital. The acquired causes include compressive, which may be secondary to any aneurysm or mass lesion, demyelination, vascular causes as in form of ischemia or other risk factors, and trauma. So there can be certain syndromes which are associated with third nerve depending on its site of lesion. So various syndrome, when the red nucleus is involved, you can have third nerve palsy with contralateral extrapyramidal syndrome known as Benedict syndrome. If the corticospinal tract is involved, then you will have contralateral hemiparesis known as Weber syndrome. If the cerebral peduncular is involved, then you may have North-Nagel syndrome. So third nerve palsy can get affected and is more commonly affected in subarachnoid space, where it can present either as isolated pupil involvement, isolated pupil sparing external ophthalmoplegia, and ophthalmoplegia with pupillary involvement. So each one of them have their own characteristic. Why pupil is more commonly involved in a compressive lesion? Because as you all will know that the pupillary motor fibers are the external fibers. They are present in the outer part of the nerve. So any kind of extrinsic compression is going to involve the pupil fibers first before they actually cause ophthalmoplegia. While the vascular supply to the nerve is at the center of its core, so whenever there is a microvascular occlusion, the ophthalmoplegia is first to get to manifest, and pupillary fibers are last to get involved. Right. So this is just to show a case of ophthalmoplegia with pupillary involvement. You can see that there is anisocoria there, and you can see a large aneurysms over there. Along with anisocoria, of course, there is external ophthalmoplegia with complete ptosis. This is another case showing pupillary involving third nerve palsy. On the right side, you can see there is complete external ophthalmoplegia, but there is also an anisocoria. And on imaging, although CT is not a good modality, but this was done outside. So on CT, we had a huge pituitary adenoma there. Isolated third nerve palsy can be pupillary sparing also in cases of vasculopathic third nerve palsy, but it's not a sacrosanct. Some of the cases of ischemic microvascular occlusion can also involve pupil. So you should be very careful before you say that this is pupillary sparing or pupillary involving third nerve palsy. You should also be careful before labeling etiology as compressive and ischemic. So you have to see how the third nerve palsy is progressing. So if it's just evolving third nerve palsy, the pupil fibers may get involved before the external ophthalmoplegia, right? So if it's just a purely ischemic palsy, then probably the pupil will be spared. So after subarachnoid space, the third nerve palsy enters into cavernous sinus, as Dr. Digvijay was telling you. And at this point, it is very much susceptible to trauma. But the trauma has to be severe enough to cause multiple brain injuries. A minor trauma is not good enough to cause a third nerve palsy and should make you suspect other etiological causes of third nerve involvement. Right? So just a small history, just a minor history, forgettable history of trauma, you should always suspect the other causes and do neuroimaging in these patients. Then third nerve palsy at cavernous sinus, third nerve gets divided into superior division and inferior division. So sometimes it may present as partial third nerve palsy depending on the involvement of the division, which division has got involved. So in this particular case, the inferior division superior division has got involved, and therefore there is ptosis and adduction limitation. Post-trauma, the patients may present with aberrant degeneration. It's not uncommon to have them aberrant degeneration, as the most common cause of aberrant degeneration is the innervation to LPS on adduction. So the nerve fibers which were supposed to supply medial rectus will also now supply the LPS also. That's one common aberrant degeneration that we see. The other common aberrant degeneration could be form of pupillary constriction on adduction. That is another form. The other manifestation could be LPS on innervation to LPS on down gaze. So whenever patient looks down, the lid gets elevated, also known as pseudo von Graffe sign. Right? So you should also look for all this while you are examining the patients of third nerve. And how do you approach such cases? So first you see whether the pupil is involved or not. If it is spared, look at the ophthalmoplegia. Whether the ophthalmoplegia is complete or not. If it's complete and the patient is old enough, has the risk factors of microvascular ischemia, you may avoid doing imaging for some time. But if it progresses, you will have to do imaging. But if pupil is spared and it is still a partial or evolving third nerve palsy, you may consider doing neuroimaging. When the pupil is involved and if the patient is particularly young, there are no other risk factors present in that patient, you will have to do neuroimaging. And the imaging of choice in all these cases is MRI and not CT. So management, you can have non-surgical management just to wait out the period of stabilization, which can be done in form of prisms or occlusion. So how do you surgically manage? So once the deviation has stabilized, you have to decide whether you want to operate on this patient and what surgery you have to do. So that depends on the amount of ocular movement that is present at your disposal. So if the movement, if there is no adduction at all, then probably you have to check for AFGT and look if the MR can generate some force or not, and then decide. If it cannot generate any force, probably the only options you have is transposing the other muscle to MR or to do an anchor. If the adduction is generated, if there is some force in the medial rectus, you may choose to do a recession of LR along with the strengthening of medial rectus. So these are just cases to show how various causes of third nerve palsy can be managed. So this case had a good adduction and we just did a resection procedure, and you can see the post-op alignment. Again, another case, this is an interesting case where you can see that the patient had aberrant degeneration, patient had elevation of lid on adduction, and this was taken into consideration while deciding the surgery, and we tend to operate on the other eye to take the advantage of that aberrant degeneration, and you can see post-op the patient had lid elevation in primary position as well. If there is no force at all in the medial rectus at all, then probably you will have to resort to an anchor surgery, which you anchor the globe to the medial wall of the orbit, or a transposition surgery where you transpose the lateral rectus to the medial rectus. So you have these two surgeries at your disposal whenever there is a complete third nerve palsy, when you cannot use any other muscle for transposition. The only muscle left is lateral rectus. So this surgery is gaining popularity day by day. So you can split the lateral rectus into superior and inferior division and then transpose it, or you can completely transpose the entire muscle from either superiorly or inferiorly depending on the vertical deviation. Coming to the fourth nerve palsy, the most common cause for the fourth nerve palsy is congenital. As far as acquired cases are concerned, trauma is the most common cause, and as you can see, and as you can recall that Dr. Digvijay was trying to tell you that this is the only nerve that exists from the dorsal part of the brain and crosses over, and that's what makes it most susceptible to trauma. So any direct blow to the midbrain or to the occipital area will cause bilateral fourth nerve palsy. So clinical features include the head tilt is to the opposite side if it's unilateral, while chin depression if it's bilateral. Patient will predominantly complain of vertical diplopia if it's unilateral, but the torsional diplopia will be seen in bilateral cases. there will be presence of extortion. So it's the common thing that you have to do in your exam or during your examination, that you have to demonstrate the Park 3 step, or you should always look for these cases because it's a good test to identify the cyclomertical muscle limitation, right? So step 1 is to see which eye is hypertrophic. As you can see here, the left eye has hypertropia, and on which gaze it increases. So in this case, it is increasing on dextroversion and while decreasing on levoversion. Again, in which head tilt it is increasing. So it's increasing on left head tilt while decreasing on right head tilt. So that's a characteristic manifestation of superior oblique palsy. The deviation decreases on the same side and increases on the contralateral side, and also increases on the same head tilt. You should always check for the torsion in cases of superior oblique palsy to demonstrate whether it is unilateral or bilateral SOP. Right? Congenital superior oblique palsies may have the facial asymmetry also, and you should also look for that. May be one of the way to differentiate it from the acquired causes. It can be classified as, and the management depends on the classification. So it can be classified as type 1. This is Knapp's classification. So type 1 superior oblique, when the maximum deviation is in the direction of IO, inferior oblique muscle. Type 2 is when the maximum deviation is in the direction of superior oblique muscle. Type 3 is when the maximum deviation is on the contralateral side. Type 4 is contralateral side and depression. Type 5 is depression. So you choose your surgeries on depending on which gaze has the maximum deviation you want to strengthen or weaken the muscle. Okay. So type 6 is bilateral superior oblique palsy, where the patient will have torsional diplopia and the torsion has to be more than 10 to 15 degrees to call it as a bilateral superior oblique. There will be characteristic V pattern because the amount of hypertropia will be very minimal. Right, and the head tilt test will be positive on either side. Type 7 is a Brown syndrome with superior oblique palsy. This is just to demonstrate a case of superior oblique palsy where an inferior oblique recession was done along with the anterior positioning to correct the hypertropia as well as torsion. This is a case of bilateral superior oblique palsy. You can see that the vertical deviation is not so much, while the patient mainly complained of the objective cyclotorsion. And here the surgery of choice is Harada-Ito procedure. Right, coming to 6 nerve palsy, yes, so these are last few slides. So 6 nerve palsy can be congenital and acquired. Nuclear lesions may present as gaze palsies. So at fasciculars, just like third nerve, 6 nerve may present with various syndromes like Raymond syndrome, which has a contralateral hemiparesis, like Millett-Guber syndrome, which has contralateral hemiparesis with 7th nerve palsy, and Foville syndrome with multiple cranial nerve involvement. It can also present as Gradingo syndrome, where you have 5th, 6th, 7th nerve and 8th nerve involvement, where there is actually the medial ear canal is infected. It's very important as far as 6th nerve is concerned. Whenever you have a case of 6th nerve, it's very important to look at the fundus, because most of the time the 6th nerve may have the false localizing sign and is a manifestation of raised ICT because it gets compressed against the petrous ligament, and therefore any sign of 6th nerve palsy should warrant a fundus examination. It can also present as an isolated 6th nerve palsy where you have vasculopathic risk factors, microvascular occlusion can be there. So again, as with third nerve palsy, you have to see whether you want to do neuroimaging with the 6th nerve palsy or not. So if there is involvement of other cranial nerves, you will have to do imaging. If it's isolated, again depends on the factors. If the patient is young, you will have to do imaging. If the patient is old, you may go ahead and observe for some time. This is an algorithm, so you have various management options. Again, if your duction movement is good, you may choose to strengthen the LR and weaken the MR. If your duction movement is not good, then you will have to do a transposition surgery, which can be either a partial vertical transposition or a full vertical muscle transposition to lateral rectus. More or less, most of us have now shifted to doing a superior rectus transposition for the 6th nerve palsy management. Last but not the least, you should never forget the involvement of neuromuscular junction, and myasthenia can mimic any kind of, nerve palsy or muscle palsy. You should always keep that in mind and should ask for the history of variability and look at the patient at different times to assess the deviation and look at the variability. So to conclude, paralytic strabismus can be a manifestation of nerve problem or a muscle problem or a neuromuscular problem. It's important to investigate for the cause, and before you operate on the patient, it's important to wait for the stabilization of deviation. Thank you.
Thank you, Dr. Swati. A very difficult and comprehensive topic you've covered very nicely in the limited time that was available. We'll go on to the next talk, which is an interactive evaluation of visual fields. So, Neuroophthalmology Visual Fields Interactive by Dr. Sumit Monga. Again, another very prolific strabismologist and neuroophthalmologist with huge experience here at Center for Sight in New Delhi. And any questions you can ask at any time. Now, preferably, of course, while we are waiting, to save time.
So, show of hands, how many of you have come across cases of, let's say, trochlear nerve palsy? Have you guys all done the Parkes 3-step test? I mean, you're all familiar with it? Okay, only a few of you, it seems. Okay, we'll come back to that later. So,
Thank you. Thank you, sir. Thank you once again. Well, I think some of us already know about, all these things. So I'll just rush through some of the things. And this is supposed to be an interactive talk. So just be ready, for some teasers. So why do we exactly need to do that? Basically, visual fields is an important part which helps us to assess the functionality of the visual pathway. And it is one system where we can actually topically localize the lesion. Apart from the other investigative devices, it's a very important clinical tool to help you make a diagnosis where exactly the problem could be. And obviously, you can monitor the disease, and it's obviously an important part of unexplained visual loss workup. So some of my examples are, from this chapter which I wrote for, this book. You can actually just search it up. So we are lucky that, we don't have statistical parameters like glaucoma to really look into the mean standard deviation, the pattern standard deviation. But generally, neuroophthalmic conditions do present with, scotomas, which are quite, easily seen on gray zone as well as the pattern standard plots. This is one example where the gray zone showed advanced constriction of the visual field, while the pattern standard settled that it was basically an altitudinal field defect. Another example where the advanced field defect was shown on the gray zone, but there was no PSD. So we have to be, aware of these things. And this was basically an advanced constriction of the field of retinitis pigmentosa, where we wanted to do a 120-point screening test also to really assess that how the patient feels, what exactly is the functional limitation. Another example where in case of thyroid, if you see the pattern standard deviation of a 30-2, we could see on PSG the early compressive damage which was in the form of a scotoma, and this was because of the muscles compressing the optic nerve. So all these strategies one should be aware so that, one can actually order and interpret accordingly. So another example where we actually had very mild defects, on the 30-2, and when we did the 10-2 field, gross central scotomas were visible. So, and which was confirmed on OCT as well. So, what is this field? What is the pattern that you see in this field? Can anyone volunteer? So, this was a WhatsApp that I received that, Sorry? Right. So, binasal, yeah. So, the first thing that we need to see is that what exactly are we doing? This is a field which is presented on the right side, but is it exactly of the right eye or the left eye? So that is very important to understand. So you know that in a visual field, the center of the eye is actually the fixation. So the disc is exactly nasal to the macula or the center point of the fixation. So in a left eye field, where you will have a blind spot towards the left side, and a right side field would have towards the right side. So it's very important that we actually see the field as if you are the patient. The patient's left eye field will be towards your left hand side, and the patient's right hand field will be towards your right hand side. So if you see in this above field which was presented, we don't really see a blind spot on the right side. So that's why this is of the right side field, because the scotoma is camouflaging the blind spot, and in the left eye also, similar thing is happening. So we have to flip these fields so that the left eye field is on your left side and the right is on your right side. So what we actually were terming as a binasal hemianopia is actually a bitemporal, and that makes all the difference. Pituitary gland tumor was this patient, that's what it had. So which is this field? Just look at it carefully. We are presenting both the right and the left. Which is the right and which is the left? Yeah, absolutely. There's no fixation point. Why? Because this is the 10-2. And what it means is that you are actually using the 10 degrees on either side of fixation. Your disc is exactly 15 degrees. So it will not show the blind spot at all. So this is 10-2. So we should be aware exactly when the field is kept in front of us. And of course, you can have the parameters from the above that, what exactly is the right and what is the left eye. So this kind of thing, is needed in vivas, because sometimes we do get confused. Dr. Digvijay has beautifully illustrated. So let me just take you forward, and I present you 4 options. Which of the following is not caused by a conventional neuroophthalmic pathology? Just carefully observe. A, B, C, D. Yeah, so let's go stepwise. So A, what do we see? Left eye or right eye? The visual field defect. Left eye. Left eye, altitudinal field defect. And Dr. Digvijay explained that, we have the infarction happening in one half because the pattern of vascular supply is such. So it's an altitudinal field defect, mostly seen with ischemic optic neuropathies. Although with the, advent of new pathologies, it's not a pathognomic of ischemic optic neuropathy. Nowadays, you have optic neuritis like atypical optic neuritis leading to ischemic events causing these kind of fields. So overall, you can say it may be an ischemic pathology, most likely non-arteritic or arteritic optic neuropathy causing this kind of field. B, what do we see? Left eye field defect or right eye field defect? Right eye field defect, and mainly it's involving the central point, the fixation, the central scotomas and the central cecal scotomas. So again, generally in optic neuritis or toxic optic neuritis or nutritional optic neuropathy, which are all neuroophthalmic conditions, you do see, these kind of things. Now what's happening in C? So we are seeing a biarcuate kind of defects, probably which started in the nasal retina, and they are actually arching above the papillomacular bundle and going towards the blind spot. And that's because, when you have a raised IOP, you have, if you just, have this diagram. So what is happening is you have the central point of fixation. Anything which is, going arching above, there is a temporal fibers, superior temporal fibers and inferior temporal fibers. Now, because when you have raised IOP, the fibers which are long enough, they are affected first. So when you have temporal fibers, affecting either inferiorly or, above the horizontal raphe, they will lead to nasal field defects. That's why nasal field defects, are something, which are early field defects of glaucoma. And the central fibers are preserved even, later in the disease as well. So this is something which we have to understand. And the last one is obviously a enlarged blind spot seen in papilledema. So you may have some typical visual field patterns depending on the fibers involved when you are actually dealing with optic nerve head pathologies. So these are some of the things. Okay. So which of the field defects is caused by a cellular or a paracellular compression? Just watch carefully. A, B, C, D. choices. Don't be in a hurry, see all the things. Actually, all of the above. Why? Let's see. So normally we know that there's a nasal crossing of the fibers. So you would have a complete homonymous hemianopia, which is, characteristic of chiasmal compression. But the pituitary gland, which is the most common cause of chiasmal compression, actually is inferior to the chiasma. So when it starts compressing the optic chiasma, actually it leads to superior defects, which are bitemporal heteronymous hemianopia. So it may start with a superior, field defect, which is respecting the vertical meridian. Or when it is supracellular compression, like a craniopharyngioma or so, it will cause a compression from above the chiasma. And that is why it lead to more of inferior. So this kind of up-down arrangement of the fibers, remember, we'll see it later, it maintained from the retina to the occipital cortex. The fibers which are above and the fibers which are below, they maintain this kind of topographic arrangement from the retina. So if you have an inferior retinal lesion, it will lead to a superior retinal defect. Okay? Similarly, you have this kind of arrangement going from front to start all along the visual pathway. Let's see the scenario. You saw this kind of field defect. I had just put this kind of field defect or only in the one of the eyes, the right eye. Now, if you have the history of this patient, the patient had actually, this female 32 years old, had 6/9 vision in one eye and almost no vision in the left eye. And that's why no fields are there. But no fields means the patient has, a kind of complete scotoma, an absolute scotoma. So if you just put it together, so you have a complete scotoma and this field which is seemingly looking normal, we have a scotoma on the periphery, of that. It may be just discounted as an artifact. But actually this was a scotoma which was caused because of the prechiasmal compression. Just at the junction of the optic nerve and the chiasma, you had a lesion which was compressing one of the optic nerve fibers, and it can be better seen, if I just show you this. So if you just have a large diagram of the chiasma, so if you have a lesion, which is just functioning at the, pushing at the junction of the optic nerve, the right optic nerve and the chiasma, the right eye optic nerve will be completely knocked out. So it will lead to a complete scotoma, and the one believer need the fibers which are looping, before they are crossing, they would be knocked out on the other side. And that is what the nasal fibers lead to a contralateral scotoma. And that's what we call a junctional scotoma. It may not be very well seen on a 30-2, but if you do a peripheral field like 60-4 or so, you may actually, see that little well. So this is one thing which you have to watch for. Although on 30-2, you get a glimpse of it. And it also respects the vertical meridian. There's something called a junctional scotoma of trichoir. That is often confused with a normal junction scotoma. But beware, what's happening here is that we just mentioned that the nasal fibers, looping around the one billion Lee, that was also compressed. But in a junctional scotoma of trichoir, it's actually the lesion just pressing either on the nasal or the temporal fibers of only one nerve. So that means, if you have the nasal compression of only, say, the right nerve, it will lead to a temporal field effect in that eye only. There will be no contralateral field effect. So the junctional scotoma of trichoir by a Scottish, neuroophthalmologist, trichoir, was only for one eye. So here you see a junction, a field effect which is respecting the vertical meridian only in one eye. So this is something, we should be aware of, that these kind of scotomas may be visible. Which of the following field effects is caused by an optic tract lesion? Just see the four options. So you have some kind of hemianopias, which
Dr.
can
Sumit,
be.
we'll have to
We'll have to
wind up
just
quickly, huh?
Okay. So basically, what we are saying is that in optic tract lesion, we have the temporal fibers and the nasal fibers, the uncrossed temporal fibers. So we'll have a incongruous homoanopia compared to a lesion which is in the posterior visual pathway, which will have more of congruous, hemianopias. And the other features which actually can be seen in optic tract syndrome is a bow tie kind of optic atrophy or a congenital RAPD. You can read about it. These are very classical things. Now, presenting 4 fields where you have to find out which is unlikely to be caused by an occipital lobe pathology. So if you see this first one, this is a complete hemianopia. Yes, it can be caused because as you go posteriorly, the fibers get more denser, they get more compressed compared to a radiation. So this can be one of the occipital lobe lesion. And in the B, the central part, the occipital tip, it leads to a maximum representation from the macular fibers. So this is also one thing, which can lead to a homonymous hemianopia, which is in the central fields. It is respecting the vertical meridian also. But see the choice C. This is more of a quadrantopia rather than a hemianopia, which is basically, when the radiations are going in the temporal lobe, the Mayer's loop, then you will have a superior field effect, which is called the pie in the sky. And if you see the D part, this is basically a classical homonymous hemianopia with macular sparing, which is again, very classical of occipital lobe lesions. So this is what I was trying to tell you, that there is a topographical arrangement in the occipital lobe. So the tip actually controls the macular fibers, and then you have, different parts. If they get selectively involved, then you can have all these kind of fields in the occipital lobe. So the learnings are that the more posterior you go, the more congruous the field becomes. And the up and down arrangement, as we just saw in the previous example. So this is a special type of lesion for the LGB lesion, where you have 2 different circulations supplying the lateral geniculate body. So here you can actually see, instead of the hemianopias, something called a sectoral or a wedge-shaped field effects. So I think Dr. Ashwin has a beautiful thing, and he would probably talk about it. So I'll go to this functional visual loss, which basically is just to tell you that sometimes we do have visual loss, and just by seeing the fields in isolation, you might just get confused. But if you see the clinical examination of the patient may not really have any deficits which correlate with the field. So it's very important to correlate the clinical and the field findings. And how you can actually judge is the advanced field effect would be same at 1 or 2 meters, which is called a tunnel vision, in a functional vision loss, while a proper advanced field effects which might be there, it might just improve as you go forward, because the arc is improving. Sometimes the patient may not be really cooperating at all, but a confrontation fields can actually just give you the clue exactly what could be happening. Like this lady with severe headache, she was not cooperative, everything came out black, but actually she was case of pituitary apoplexy. And then of course you can monitor, like in papilledema you were monitoring that how exactly the optic nerve function is behaving. And this is just a summary of all what we talked about. Thank you very much.
Thank you, Dr. Sumit. Excellently covering a very, very important component of the neuroophthalmology workup and examination. We next have Dr. Ashwin Gandhi, who will be talking on localizing the lesion interactive. So you can expect a lot of fun in the next half an hour, knowing Rashmin.
Thank you, Professor Saxena. A lot of localizing was covered very beautifully by Swati and by Sumit. So we're going to have some of the cases. It'll be a case-based interactive. While my slide is getting ready, what is RAPD?
Relative afferent pupillary defect.
What does it denote?
So afferent pathway defects.
So would you have RAPD if patient has, let's say, nutritional optic neuropathy with 6/24 vision in both the eyes?
No.
Why?
It's a unilateral afferent pathway defect.
Very good. So when you say RAPD, relative to what?
To the other eye.
All right. So RAPD is one visual pathway versus the other visual pathway. How would you test for RAPD?
Swinging flashlight.
Swinging flashlight test. Very good. Can you describe very quickly how do you perform swinging flashlight test? Swing a flash.
The room adaptations should be in dim light. Then we cover the nasal bridge. We see the direct and indirect light reflex. So when we do the direct,
All right, we will come to that. So let's start with the case. I want to talk about this patient who came for a second opinion. He said that I was hit on the head repeatedly during a fight, and after that, my eyesight gradually went down. His visual acuity in the right eye is 2/60 and 6/9 in the left eye. And this is how his optic nerves look like. Obviously, right eye, you can see there is an optic atrophy. So he was told that you have traumatic optic neuropathy and nothing can be done. And that's how he came for a second opinion. What do you think? Anything that you think is not comfortable for you with the diagnosis? You can, shout out if anybody knows the answer. Otherwise, I'll come to you. Yes? Very good. So what you're worried about here is that patient complained of gradually progressive loss of vision, which is not a feature of traumatic optic neuropathy. Can trauma produce a gradually progressive loss of vision? Is there any situation where patient has a trauma and has a gradually progressive loss of vision? Is there any situation where it is related to trauma, but a gradually progressive loss of vision? It can happen if patient develops optic canal fracture and if the bone is impinging on the optic nerve. The bone then acts as a compression of the optic nerve and the vision will gradually go down. Very good. So you are not very comfortable with the diagnosis because you said that patient has gradually progressive loss of vision. Anything here? Yeah.
Right eye disc pallor, right eye disc.
Excellent. Right eye disc pallor. Anything in the left?
Blurred disc margins in the left eye.
Yeah, I agree. If you say blood disc margin, I agree. I said that let's ignore it. Anything else? Temporal pallor, very good. That means that there is something going on in the left eye. We have still not defined it, but there is something in the left eye. Now, if I say that it's not only temporal pallor, nasal also, very good. So there is a nasal pallor and there is a temporal pallor. What do you call this? Bow tie optic atrophy, very good. Why would you see, or when would you see a bow tie optic atrophy? Sumit mentioned about it in one condition. Yeah. No, nutritional will not cause a bow tie optic atrophy. AI1 will not cause, it will cause a sectoral optic atrophy. AI1 will cause sectoral optic atrophy. A bow tie optic atrophy is generally a feature of chiasmal compression. Optic chiasmal, what kind of visual field defect you will see? Sumit just mentioned, one of the commonest defect is bitemporal hemianopia. That means the temporal visual fields are not working. Which fibers in the retina serve the temporal visual field? Nasal fibers. Nasal to what? Nasal to nose. No, what? Nasal to fovea. Excellent. Nasal to fovea. So if you see here, this is fovea. These fibers go like this. They are called what fibers? Papillomacular bundle. These fibers go and attach like this. What are these fibers then? Arcuate fibers. They are affected more in or early in glaucoma. While these are affected in chiasmal compression, which serve the temporal visual field. So if you see this kind of pallor, you already are thinking of compression of optic chiasm. And so now what kind of visual field effect you will find here? If you say that there is a chiasmal compression, but one eye has gone into complete optic atrophy, if you do a visual field, what kind of visual field you like anticipate? Junctional scotoma, because one eye has an optic atrophy, so that will have an optic nerve kind of defect. This eye would have a supratemporal defect. So in other words, we are not dealing with traumatic optic neuropathy. We would do, what would you do now? Neuroimaging. What?
We'll do an MRI.
MRI of hip joint.
MRI brain.
Very good. MRI brain and orbit. Anything else?
With
No MRV. MRI, most of the time you'll say MRI brain and orbit with contrast, and you would have to talk to radiologist and say that this is what we are suspecting, because he might run a special sequence. If you're suspecting optic neuritis, you say that maybe optic neuritis and run a special sequence. Anyway, we move on and say that no, this is not traumatic optic neuropathy. We did the MRI. Is this MRI or CT scan? Oh, by mistake I put a CT scan here. Is MRI only? Okay, what section? Coronal section, right? This is an axial section of MRI, is where you find this is the problem. This is a pituitary tumor, which is what patient was suffering from. Trauma was incidental. Okay? All right, so that's case number 1. So what we learned there is history is not everything, but sometimes that's the only thing. Gradually progressive loss of vision should have alerted you to do more investigation. All right, now see if I can run this video. Yes, I can. Look at this pupillary reaction. I'm performing swing flashlight test in a slow motion. What did you find? Yeah. Left eye RAPD, denoting that there is a left afferent visual defect. The steps of performing a good swing flashlight test: always in a dark room, patient looking at your nose, right at your nose, and correct?
Distance object.
Why not at your nose?
Accommodation.
Right. You will stimulate a near reflex, causing meiosis because of a near reflex. What would you do next if you see this kind of left RAPD? What's the next step?
Visual acuity.
Visual acuity was 612 here.
Color vision.
Yes. What's the importance? Sumit and both Digvijay mentioned the importance of checking color vision. Can you differentiate what would have caused an optic neuropathy just by color vision? Not to absolute conclusion, but you say, oh, I'm getting some clue now.
रेड क्लीन डिफेक्ट होता है
No, within optic neuropathy, can you differentiate between what would have caused optic neuropathy just by doing color vision? Multiple sclerosis? No. So color vision can also give you a small clue to differentiate between optic neuritis and AION. Optic neuritis would have much more profound color vision deficiencies. Snellen's visual acuity can be normal. While in AION, ischemic optic neuropathy, you will have both going parallel. You have a Snellen's visual acuity drop and proportionate drop in color vision. You can't base your diagnosis only on this, but you're getting a clue a little bit. Okay, change tracks. Professor Saxena, please do let me know when my time is done.
Sure, sir.
Thank you, Professor. Now we talk about the pupil. So this is the second scenario. So we have a pupillary size which is 6 millimeter and 3 millimeter. This is just a representative pupil. And so what's anisocoria more in dark? What are your thoughts? Which system is at fault? Sympathetic system, because sympathetic system is supposed to dilate pupil, right? And if in the dark one pupil does not dilate, anisocoria is going to become much more. If sympathetic system is at fault, what syndrome you are thinking of? Horner syndrome. So if I give you, or if examiner gives you a scenario where patient comes to you with a fall, elderly patient, and has a painful Horner syndrome. You are seeing the patient on Friday evening in the OPD, and what would you do next? He came to you because he said, oh, my glasses are broken when I fell down. Maybe that's why I'm having headache. You examine the patient, you find Horner syndrome. What next?
Or a cervical. Chest X-ray including the cervical scans.
Okay, chest X-ray including cervical span.
Like something related to the investigation of the flow of the third nerve की जो blood supply है उसके लिए
So we are not dealing with third nerve, right? What third nerve palsy will lead to what kind of pupil?
So dilated pupil.
We are talking about a small pupil which is at fault. We are thinking of Horner syndrome, which is the exactly opposite system. third nerve is parasympathetic.
We'll check for the level of horniness, whether it's central, preganglionic, or
How do you do that?
cocaine test.
Generally, where do you get your cocaine from generally?
Hydroxyamphetamine test.
Even that's not available.
Adrenaline.
All right. So, yes, of course, cocaine, hydroxyamphetamine, epinephrine, all those tests are textbook tests. You probably would have to mug it up because some examiner might ask you. But practically, they are not available.
We use Tropac as a because cocaine and the amphetamine is not available.
Unfortunate.
Yes. So we use Tropac.
All right. So you're all fixated on a pharmacological test. Well, I say that Friday evening patient has come. You say, okay, I'll somehow arrange cocaine on Monday. Come back on Monday. Is that allowed? My point is something else. I want to emphasize that a painful acute Horner syndrome is an absolute emergency. He partly alluded to what he sort of on the right track. Aneurysm is more on the third nerve.
There might be an aortic dissection causing.
Fantastic. Dissection of larger vessels, and let's look at some data to. So this is, you can see here, the left pupil is smaller, right pupil is normal size. I'll also project one more picture. This was acknowledged Dr. Devendra Varadarajan Venkatramani, who is here, and we'll hear from him very shortly. This is a very beautiful documentation of Horner syndrome. You say here, dim, the anisocoria is little more than the bright light. This is how you come to a conclusion. Anisocoria more in a dim light, Horner syndrome, or sympathetic system, anisocoria more in a bright light, parasympathetic system. Now, why this is an emergency painful Horners is because dissecting carotid aneurysm, last line, it can remain isolated in half of the patient. One more important point. Look at this. 50% of these can present to ophthalmologist. Now, this can be fatal. Dissecting carotid aneurysm can lead to stroke or MI. So if you see this, it's a medical emergency. Either you take help of radiologist or a neurosurgeon, or advised, as he was saying, MRI with MRA of neck vessels. So partly you get that right. All right, 60% of these people have permanent neurological damage, 5% mortality. Horner syndrome can be a short note for you. You may get a cold case. What are the other features of Horner syndrome? Apart from anisocoria, which is worse in dim light, what else would you see? Anhidrosis is last. Ptosis, mild ptosis. Why would patient get mild ptosis? Muller's muscle, very good, excellent. Then you go to the theory of anhidrosis, loss of ciliospinal reflex and whatnot. Okay, one more case. This is a 30-year-old gentleman. Look at the ocular motility. What type of ocular motility being checked now? Smooth pursuit or saccades? What did you see? Patient looking to the right and left, up and down was fine. I'll run it again. Okay, look at it carefully. Patient looking to the right. Obvious abduction deficit of the right side. And looking to the left, abduction deficit of the left side. Sorry?
By internal nuclear ophthalmoplegia.
Okay, bilateral INO is called Webino, wall-eyed bilateral intranuclear ophthalmoplegia. This was not the adduction. One of the feature which was missing here is that in that there will be an obvious limitation of adduction. Of which eye? Ipsilateral, if there is a right INO, which eye will not adduct? Right INO lesion would be in which area of the brain? Right medial longitudinal fasciculus. INO, internuclear ophthalmoplegia, is a problem which affects medial longitudinal fasciculus, which connects the third and the sixth nerve. So if there is a MLF problem, patient will have INO where ipsilateral adduction limitation and contralateral abduction nystagmus. Yeah. So this is bilateral abduction deficit. Possible causes?
Papilledema, sir.
Raised ICP, what is known as false localizing sign. Remember, false localizing sign is much more likely to be bilateral than unilateral. Why would you get a false localizing sign in raised ICP? Yeah, why?
Compression of the sixth nerve.
That happen?
Sir, the nerve passes through the Dorlow scale.
Exactly, it's the way nerve passes. A lot of times we make a mistake and say because it has a large intracranial course. Please remember, fourth nerve has a much larger intracranial course, but it's not involved in raised ICP. It's because the way it passes through. All right. So that's about one more case. Yes, very good. Somebody already noticed a ptosis. This is, we are checking in ocular motility. Patient looking to the right, left. What do you think is happening? Looking up.
Myasthenia gravis.
Why did you say that?
Because as the patient is exerting herself, the ptosis is increasing.
There is a clear increase in ptosis of the right side, even left eye has become ptotic, implying the patient has fatigability positive, having ocular myasthenia gravis. What are the other tests that you will do? Before that? Not before that, in the OPD. Fatigability was demonstrated. Anything else?
If you ask the patient to close her eyes, eventually the lids will move up and you will be able to see the sclera peaking inferiorly. Peak sign.
Kogan lid twitch.
How do you perform? All right, anybody? Kogan's slit twitch is a good answer. So Kogan's slit twitch is seen, in fact, probably it was demonstrated. You ask the patient to look down for around 20 to 30 seconds. So patient keeps looking down for around 20 to 30 seconds. Then you ask them to make upward saccades in a primary position. So patient looks down for 20 seconds, and then he looks at, or he or she looks at your nose quickly. So when they make that upward saccades, the ptotic eye goes up, does like this before it settles down. It flutters. So that's called Kogan's slit twitch, one of the signs which would point towards ocular myasthenia. The other important sign would be tone of orbicularis oculi. Reduced tone of orbicularis oculi is one of the important early signs of ocular myasthenia gravis. Eyes test, how do you perform? How many minutes? 2 minutes. In which situation in ocular myasthenia gravis? It's a very specific and sensitive test, but in what scenario you will not rely on eyes test, though you know or you suspect ocular myasthenia? No, you suspect. You know it is ocular myasthenia, but you say, oh, even if eyes test is negative, I don't mind it. I still would go ahead and investigate or treat ocular myasthenia. Eyes test has a very high sensitivity for partial ptosis. It does not work as well in complete ptosis. So if complete ptosis, it reacts very good, does not react, you still go ahead and investigate. Okay? We move on. What's the fallacy of missing out all this is what can happen. This is the patient, the upper two pictures are preoperative pictures. You can see he had this kind of ptosis, and he wanted a correction for it, and then the team which examined him said that, yeah, it can be corrected easily. And the last two pictures, the bottom two pictures are post-op pictures. Not only that ptosis increased, now he has a lid lag. So if you operate in these situations where the primary pathology is not addressed or is progressive, you would not only have failure of the surgery, but in fact can be worsening of the problem, which patient would blame on your surgery. So it's very important to make sure that you suspect myasthenia in almost every acquired adult ptosis. One more, 4 minutes? All right, so probably this will be the last case. What's the most striking feature? A young girl with bilateral symmetrical ptosis, near symmetrical ptosis. Now patient is trying to look to the left, trying to look to the right. myasthenia would feature in differential in all the patients who have an acquired ptosis and ocular motility problem. It would be one of the differentials. Only in one situation we say, yeah, whatever it may be, this is not myasthenia.
When the pupil is involved?
Excellent. Please remember, myasthenia for all practical purposes, clinical pupil is never involved in myasthenia gravis. So if you say ocular motility problem with problem, it may be something else. All right. CPO, what next? What would you see in fundus?
Salt and pepper fundus.
Pigmentary retinopathy is one of the features. Okay. What else? What would you do with the patient? You say, yeah, this is CPO.
Muscle biopsy.
Okay, to confirm, all right.
Mason trichome stain, we will see ragged red fibers.
Ragged red fibers, okay. Then you did all that. Then, very good. Don't forget this. These patients have high propensity to develop heart block, so they should be examined by the cardiologist to make sure that they don't have this problem with heart block. I think in the interest of time, I'll stop here. If there is any time that we have during the next few days, I will continue with this case discussion. If anybody who didn't see the nystagmus videos, catch me during the lunchtime and afterwards, I'll show those videos. Thank you very much.
Thank you, Dr. Ashwin.
Now I would like to invite Professor Rohit Saxena from RPC AIMS. Professor Rohit is one of the most prolific pediatric ophthalmologists and neuro-ophthalmologists. He has really published amazing amount of original work in the last few years. In fact, we went to APO last week, and a lot of international faculty were all praised for his publication. So we're really fortunate that he's here, and he's a fantastic orator and a teacher. So thank you, Professor Rohit.
Thank you, Dr. Rashmin, for those very kind words. Following Rashmin is a very, very hard act to follow, as you must have seen. His presentations are extremely interactive. And what I have learned from him is that if you don't try to, follow what he does, you are going to be, the most boring person in the hall. So learning from him with my long association with him. So we'll try and do more of the same. Okay, so a lot of this has been floating around. We've been talking about it, discussing. So, I mean, I don't know why people, say neuro-ophthalmology is difficult. You're hearing the same thing again and again. We have nothing different to talk. We talked about fields. So there's nothing much we want to tell you. So probably we'll ask more questions than answers, right? So we've talked about what is normal. So Dr. Digvijay talked about what is the normal thing. So you need to, whenever you're describing a disc, color, size, shape, margins, cupping, whether present or not. Actually, cupping is absence of or non-existence of something. So cup is actually less important than the neuroretinal rim, which you need to actually mention, see, and try and understand what's going on there. Vessels and peripapillary area. So just this photograph to show you everything else is absolutely normal. Something that was only abnormal were the vessels. The vessels were tortuous. That's all. So the rest of the disc was absolutely normal. So that's just highlighting that, you could have everything normal and a very slight thing that could be abnormal. So this is the importance of a stereoscopic examination of the disc. You need to always examine. And well, we've learned so many things from COVID. And one thing we've learned, the only reason now I use my direct ophthalmoscope is to check for RAPD. Other than that, the direct ophthalmoscope is of no purpose whatsoever. So you can save money in buying the direct ophthalmoscope. So some definitions. So let's try and understand. We're talking about disc edema. Some definitions. Optic disc edema, papillary edema. That would have been great. Yes?
Blurring of the disc margin is optic disc edema. If it's bilateral due to a raised ICP, it's a papilledema. And any disc which have a blurring of a disc margin, but is not because is usually some other pathology like the disc, the vessels are not as skewed and the other retinal findings are not there. That is usually a pseudo papilledema, usually seen like an optic disc drusen kind of.
Great. So we are, it's now not moving forward. Sorry. Yeah. So disc edema, essentially true edema, there the other eye. So if it's bilateral, you have this kind of a differential, pseudo-papilledema, papilledema, hypertensive retinopathy, bilateral papillitis. I mean, whole lot we've been generally talking about or discussing. So these are differentials there. If it's unilateral, you could think in terms of whether it's hyperemic or pale, although these are very gross, not so clear-cut, differences, because over time, even a hyperemic disc may start going towards pallor because of the damage to the nerve fibers that are happening. So your unilateral could be papillitis, ischemic neuropathies. You could have unilateral pseudo-papilledema or pseudo-disc edema also. You could have retinal causes, and of course, rarely asymmetric papilledema that it presents in one eye, and of course the other eye is at the moment normal, but may soon develop edematous changes. And of course, you may have the other eye showing optic atrophy. Again, it's showing that this process that you're seeing in this eye may have happened earlier in the other eye. So these are gross differences between papilledema and pseudo-papilledema, but we'll come back to this. Now, which is which? What is A? Yes, shout. I said, when in doubt, just shout, yeah? So, A, disc drusen, okay. B, papilledema. C, so great here. I think neuroophthalmology at the end of the session, you guys are too good. So the first one is pseudo-papilledema. Now, right now, for just on the appearance of the disc, it's not possible to know whether it's due to a disc drusen or it's just structurally like this, but that's pseudo-papilledema. We'll just come back to the differences between the two. The B is true papilledema. You can see obscuration of vessels, you can see some exudates there, you can see the hemi-star exudative pattern that's going right up to the macula. And the C is hypertensive retinopathy. The way to differentiate, you may not have edema here. So some places you can see that disc in this side is obscured. The important thing to remember is that a lot of changes you are seeing, they have normal retina in the middle. So this is telling me that a lot of pathology is there, and some of it is not directly related to the disc. But if you look at picture B, everything is connected. There's no normal retina in the middle. So that's all. It can be severe edemas can go across the macula, can really involve a large part of the fovea. But they all are connected. The fluid is connected. It starts getting absorbed in the middle also, but you'll get exudative, you'll get some exudates there. So pseudo and true vision, of course, pseudo-papilledema is usually normal, although drusens can give rise to some level of field effects. Pupils are normal. Papilledema, you may start seeing visual functional deficits. Optic cup is obscured. So there's no, because of the fluid collection, there is no cup. There may be a cupless disc in pseudo-papilledema. You have the other things like the Patton's lines, you have obscuration of vessels. The vessels will be very distended and tortuous, hemorrhages, and of course fluorescein angiography, which nobody does now. So again, just to show you, so this is again papilledema. You can see obscured vessels, hemorrhages, hard exudates. On the left side, the margins are not clear. It looks kind of elevated or bumped up, but you can see, you can follow the vessels. They are there. The margins beyond the disc, the retina, peripapillary retina is essentially clean. So that's how you will differentiate papilledema true from false. You have gradings, grade 1, grade 2. I mean, these are more theory than practically, but it's important to know how it evolves over time. So how the fluid evolves over time, how the changes occur. Sometimes when you're not very sure, this is of course well established, so this is the most common picture that we see. Sometimes when you're not very sure whether it's early disc edema or not, OCT can help, and sometimes even when that is not clear, you would probably want to just follow up the patient in a bit and identify. So you have a lot of symptoms associated with raised intracranial pressure, nausea, vomiting, headache, 6 nerve palsies. Why does 6 nerve palsy happen? So what is false about it? Why is it called false? I mean, you're seeing it happen, so what's false about a 6 nerve palsy there? So 6 nerve palsy, even if it's microangiopathy, will resolve without doing anything? Superb. So One thing we've learned during all this interaction this past, that your clinical picture is helping us to isolate where the lesion is. That's why it's a false localizing sign. Otherwise, any neurological deficit that patient presents with can localize to somewhere in the brain or the pathway. But the sixth nerve palsy will not, in this condition, will not help me to localize it to say the pons where the sixth nerve nucleus is. Now, why does it happen then? What's going on there? Compression of what? Of the nerve. So what is happening? There is raised intracranial pressure, there is a downshift or coning that can be happening, so the brain has no place to expand because of the skull. The only place is the foramen magnum, so the midbrain starts getting pushed down. The sixth nerve is fixed at two places, one at its origin from the pons and the other as it curves over the Dorales canal. So it gets stretched, there is damage to that, and that's why they present with sixth nerve palsy. And as the pressure resolves, the brain goes back, it can resolve on its own. And of course, the other features can be present. Dr. Digvijay talked about these are Goldman fields. One of the early presentations can be an enlarged blind spot, generalized constriction of the visual fields. You must remember, we talked about, Dr. Rashmin said, MRI brain in orbits with contrast. It's important because you need to localize. There could be a tumor, there could be hemorrhages, there could be increase in, because of meningitis, aqueductal stenosis, and IIH. So it's always, the MRI is the investigation of choice. Other investigations can be a lumbar puncture if you want to know the pressure or you want to know if it's associated with infection. So all these things have to be ruled out based on the investigation, based on your investigations. You neuroimage to rule out a space-occupying lesion. You will see the signs of distended optic nerve sheath. Empty sella is a soft sign, not a great sign, although the radiologists are very, very, very interested in that. Once you have a patient with IIH, an MRI has to be followed with an MRV if the MRI is normal, because of venous sinus thrombosis is the other association of a papilledema or a raised intracranial pressure because of IIH or its associations. Weight loss, the most difficult thing to do in life. But other than that, identify the other things like blood pressure, anemia, obstructive sleep apnea. These are now the important things that are being identified as associations. So while you are intervening or managing medically, these are things. Diuretics, acetazolamide is the sheet anchor for treatment. Surgically, you have shunts, a lumbar peritoneal or a ventroperitoneal shunt, or an optic nerve sheath fenestration. So if the field defect is the primary problem that the patient is having, you think in terms of shunts, of fenestrations. If headaches, tinnitus, very, very high pressures, fulminant IIH patient comes with, think in terms of shunting. Now you have unilateral disc edema. It could be hyperemic or pale most commonly associated with an ischemic optic neuropathy. Optic neuritis, the most important and the most common hyperemic disc problem. So the most common presentation would be sudden onset loss of vision associated with pain, specifically written in the books on looking superiorly, but anyway, pain on eye movements. Why does this happen? Yes?
Medial rectus and superior rectus are combined with the, attached with the optic nerve head, so
they are around in that annulus of Zinn. So that's where, so when it moves, because of that, there is inflammation there. When it moves, it causes pain. So that's why there is pain on eye movements, a very important sign. Usually unilateral, as I said, visual function reduction. So you need to check all the visual functions. So visual acuity is just one of the visual functions. Patient may come that I'm not so seeing clear in this eye, but you check the visual acuity, it's 6/6. So you say, hey, there's nothing wrong with you. But that may be just the early presentation. And this is not just true for neuroophthalmology, any condition for that matter. Color, contrast, fields. These three are the key essentials, just like you test for visual acuity. Clinically, you should test for these things. Whether you get them investigated or so, fields just by confrontation can help you. RAPD in unilateral cases, and of course swelling of the disc, or the disc may be normal in a retrobulbar neuritis. So management, this has been discussed ad nauseum. Yes?
reduce the intracranial pressure. Sir, steroid. Steroids, sir. IV
IV methylprednisolone. So you have a choice of no treatment, although now we don't really consider that, but that was earlier being discussed. But now IV methylprednisolone is the intervention you must do. You must rule out systemic infections. That is very important because you don't want tuberculosis in our country to flare up. And of course, remember, oral steroids are contraindicated. They have been shown to increase the recurrences. Pale disc edema, NAION, and arthritic AION. NAION is the most common ischemic neuropathy presenting to us. And however, it is very, very important to differentiate an arthritic from a non-arthritic at the time of presentation. That is the key presentation difference that you need to make, because your investigations and management are going to change accordingly. NAION can present with essentially altitudinal field effect, and that's very common because the vessels are being, the blood supply is to the superior and inferior part of the disc, and you have blood flow problem or an ischemia to one part of the disc that causes damage in that part of the disc, and the other area is normal. So you may just have a small altitudinal field effect. More common field effects are inferior. Again, there is unfortunately, no real treatment for NAION. The important is to manage, identify, and manage the associations and the risk factors. Diabetes, hypertension, hyperlipidemia, sleep apnea, nocturnal hypotension. Patients who are on hypertensive medication are at risk if they take their antihypertensive medication very late into the night. So we know that the blood pressure dips sometime early, in very early hours of the morning. And if it times with the antihypertensive you've used, that can result in severe blood flow compromise to the optic nerve head. And that can precipitate an ischemic neuropathy. And that's why the classical presentation of ischemic optic neuropathy, the patient wakes up in the morning and says that he was seeing blurred with one eye. So that's the most common presentation that they come with. The other things you need, then what is this small cup to disc is predisposition to AION. They are called a disc at risk. In fact, the other eye you would have this small disc with the absence of cup. There is no space in the disc for even minor compromise in blood flow temporarily. So the edema that comes immediately causes a compartment syndrome at the optic nerve head, causing that ischemic damage. So this is the other predisposition, structural predisposition. Hypercoagulopathies, anemia, a history of acute blood loss, migraine, smoking. So all these things need to be asked for, identified, and of course managed appropriately. As I said, other than that, there is no clear therapy of proven benefit. A lot of interventions have been tried. None of them have found to be more successful or more effective than doing nothing but managing the risk factors. Arthritic ischemic optic neuropathy, on the other hand, is an emergency. There are very, very few emergencies that present to ophthalmology that somebody has to wake you up in the middle of the night and say that, please do something for this. Trauma is, of course, one. Arthritic ischemic optic neuropathy is one such condition. Sudden onset loss of vision. Patients may have transient visual obscurations earlier. Ask for any patient you suspect ischemic optic neuropathy, ask for headaches, jaw claudication. So when he's chewing, so what is headache? What are the kind of headaches? They're superficial temporal headaches. All of us have headaches. I'm sure you must be having it by the time I'm like, 2 hours into neuroophthalmology, nobody can go out without having a headache. So they are generally on the temporal side. Jaw claudication, so how will you identify or ask for jaw claudication? Now it's a question which, I never knew how. Do you have jaw claudication? Oh, I don't know what's jaw claudication. So how will you ask for jaw claudication? So pain on chewing, so he very quickly gets fatigued. He just starts chewing and there's pain here because there's ischemia. So the other important thing to remember in arthritic ischemic optic neuropathy, it's not restricted or limited to the optic nerve that you are having these changes. These changes are occurring everywhere in your body, and that's why the urgency. Of course, you'll ask for scalp tenderness, loss of weight, loss of appetite. So all these things are happening in the patient because this is a systemic disease presenting to an ophthalmologist. They'll come with very severe vision loss with a pale swollen disc. The important investigation, the moment you suspect such a condition, you do an ESR and a CRP, which is very, very important. An elevated ESR, CRP are diagnostic for They have a very, very high sensitivity, 99+% sensitivity for an arthritic. Temporal artery biopsy, the other confirmatory test, but because of skip lesions, it's not so easy. So consider GCA or giant cell arteritis. Advanced stages, history is suggestive, history of transient obscurations, bilateral involvement, and there are signs of retinal or choroidal. So again, it may not just be restricted to the optic nerve. You would have retinal ischemia, choroidal ischemia also. Treatment is an emergency, high-dose steroids to prevent further damage. Return of vision in this eye is rare, and the key thing is to prevent involvement of the other eye, which can happen in a very high percentage of patients within 2 weeks. So it's very important to aggressively intervene, and of course a systemic assessment, because this disease is going on all over the body. Just to show you what's going on in the disc here. Just shout. So which, the left or the right? Left. So pathology is in the left eye. Okay, so what's going wrong there? So there was pallor there. The margins are not really so obscured, but you can see that the left is pale compared to the right. What I was talking about, the small disc, absence of cup, the vessels are branching right in the middle of the disc. They didn't have space or time to actually spread out. These are characteristics of a disc at risk. The other eye, you can see that has that small pale part here, which presented with just this field effect. So this was an ischemic optic neuropathy patient presenting to us. So very subtle things you need to pick up, and again, this you may not identify as pathology. The visual fields is helping us. So a comprehensive involvement. So we've talked about, I think, all these. Digvijay talked about it. So that's myelinated nerve fibers there. This is an acute neuritis. You can see the difference in optic neuritis, papillitis versus papilledema is that in optic neuritis, you'll see mild amount of edema. You're not going to see that heavily swollen disc. It's just obscured mildly. There is a few splinter hemorrhages. The margins are not clear. But papilledema photographs you've seen, it was huge, unless it's early, in which case it may be a problem. We talked about, so where are we? So we started talking about drusen. So this is clear where you're looking at. So this patient came with difficulty in near vision. Somebody saw the occasional headache. Like I said, headache is universal. So that's what we did an ultrasound. You can do an ultrasound, CT. You can, without injecting the dye, you can do just put in the filters and see. You'll see the pseudofluorescence of the drusens. So all these are ways in which you can identify optic nerve head drusen. Otherwise, the lumpy, bumpy appearance of the disc head. Just quickly run through, we just have a little bit of time. So optic atrophy has been discussed, but I'll just talk about it. Optic atrophy is not a disease, it's just a morphological sequelae. So we need to do guessworks, what's going on, what happened, how and why is this appearance of the disc. But these are all suggestions, all these are ideas. It's not a truly definitive diagnostic appearance ever. For functional or for a start point, we divide optic atrophy into primary optic atrophy. So it's like chalky white, sharp margins, demarcated cup. The cup may be actually enlarged. Retinal vessels are essentially normal. So this is showing me that something is happening to the nerve fibers which are gradually getting lost. There was no edema, swelling of the optic nerve. So whole lot of these things go. There's a space occupying lesion causing gradual compression. The nerve fibers are getting lost. You're seeing a primary optic atrophy. Toxic, hereditary, nutritional. The damage is directly at the nerve fiber. There's no edema, swelling, inflammatory response of the body to that injury. So that will eventually or gradually present with primary. Secondary, you have signs of prior inflammation. So this, like I said, these are not definitive diagnostic, but these are presentations that help you to decide which way or what is my differential. So you have a disc margin that is blurred, there's gliosis, it's a dirty yellowish looking disc, the cup is obliterated, perivascular sheathing. Something happened to the disc earlier, and that's why it's looking, not so good now. So ischemic neuropathies, optic neuritis, papillophlebitis, post-papilledemic. So these will come under secondary optic atrophy. So this is a appearance or a diagnosis or an interpretation of the appearance of the fundus. It's not characteristic. One more thing is cavernous optic atrophy. Of course, glaucoma, people would call it a glaucomatous disc, but sometimes there are differentials to a glaucomatous optic atrophy, among them being methyl alcohol toxicity, sometimes space occupying lesion. Again, what's happening in these discs is that there is a very severe and marked and sudden loss or damage to the nerve fibers, and they suddenly disappear. So the cup starts increasing or the nerve fiber loss occurs without any inflammation, and you have an excavated disc. So methyl alcohol toxicity a month or 2 months later will present with a disc that is completely excavated. Again, we've talked, so what is on the right? Sorry, that's on the left, the right. Right is also myelinated. No. What is myelinated nerve fibers? What are they, by the way? What has happened? Great. So it stops. Sometimes it goes beyond. So it's just a congenital or a developmental anomaly. What happened in the right? So it's a disc hypoplasia. You can see the double ring sign inferiorly. So the disc is just till that, this line here. This is where, because there was no nerve fibers, so the layers have just gone up till there, till the edge. So that's why the double ring sign. The inferior ring is the scleral rim. So just a discussion about imaging that we've talked about, a patient presenting with field defects, sudden loss, do confrontation fields. Always search for cause for disc pallor. Disc pallor is like fever. You need to identify the cause for fever. What is the etiology behind the fever? What is the etiology behind the disc pallor? Why is the disc appearing pale? Whether it's a localized cause, it's a neurological cause, CNS, it's very, very important because these patients can harbor major space occupying lesions and can be at risk to life. Young adult came with difficulty in reading. You can see the fundus. What is there in the fundus? So bilateral temporal pallor, this was his field. So that becomes, again, Goldman perimetry was derived or was evolved from confrontation perimetry. We are relying more and more on automated machines to tell us, whereas everything, all signs, even glaucoma signs that we talk about, Seidels and arcuates and all those were described originally in the Goldman. So, which got derived from confrontation. So, confrontation perimetry, just by doing a confrontation perimetry, I know what I need to do with this patient, and I need to image this patient. So, that's the key message I think the entire neuro-ophthalmology session will be for you. Spend time, ask questions, examine in detail, and then go back and forth with the patient to understand what's really happening to this patient. Thank you very much for the opportunity.
Thank you, Professor Rohit, for that lovely interactive talk. So, if there are any questions, otherwise we'll hand it over for the next session.
I would actually encourage you guys to ask more questions if possible. The speakers have left 1 to 2 minutes for you guys to have discussion. So take advantage of the fact they're all here to answer your questions.